The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everybody. Welcome to the next episode of TMD Demystified. I am Tony Urbanic. Today is a special day for me and our organization because we are able to use the new studio that has just been set up that you can see behind me. I'm proud to be able to do this in a little more sophisticated way. And I look forward to any comments that you may have when we start doing our first live stream, which will occur next Saturday at noon Central Time, the date being April the 4th, 2026. But today I am inaugurating our new studio, which was designed and put together with the help of my IT technician, who is very able, very astute at putting these things together. I could never do it myself. Manny has been extremely helpful in putting together the pieces, the computer pieces, the entire process of live streaming, so it makes it easy for me. So without any further explanation, again, welcome to TMD Demystified. Today's topic is entitled, Orthodontists Can Create TMD, which is a fact. And I'm going to explain this, and I want to do it carefully. I hope I won't take too much time doing this, but I want to make some very specific points directed to my dental colleagues, specifically also my dental specialty colleagues, my orthodontic colleagues, and also directed to the many patients who watch these podcasts, because as you well know, if you're watching this, you're interested in the solution for TMD, actually what the process is, the process that creates the symptoms, which we've discussed so many times. And I have mentioned in passing that orthodontists and orthodontic treatment can create temporomandibular joint disease, and this is a fact. But I want to explain it a little bit more today. I want to define it. I want to make sure that you understand my purpose here in doing this, which is nothing more than solving this problem, widespread problem of temporomandibular joint disorder that affects a huge number of people. 45% of females in the United States of America have temporomandibular joint symptoms coming from chronic inflammation within the temporomandibular joint. But again, today's topic and title is Orthodontists Can Create TMD. As usual, let me define terms a little bit so there's no misunderstanding of what I'm trying to say. So I write a blog 2 days prior to my podcast on the same topic. So the same topic is basically covered in condensed form which is seen on our website, but in a very condensed form. But I'd like to read a few paragraphs from the blog that I wrote 2 days ago with the same title, Orthodontists Can Create TMD, to define our terms. There is a word that defines the occasions when a healthcare provider creates or contributes to a disease process. The descriptive term is iatrogenic. According to Merriam-Webster, the dictionary, Iatrogenic is defined as, according to the dictionary, damage or disease induced unintentionally by a physician or surgeon or by medical treatment or diagnostic procedures. It is derived from the Greek iatros, physician, meaning physician, and genic, created from physician. Unfortunately, there are many examples of this throughout history up to present time. Please note the definition explicitly indicates the word unintentionally. I am not promoting that doctors cause or contribute to disease intentionally. If they did cause or contribute to disease intentionally, it would be called by another name, from unethical to criminal. That is not what I'm referring to. Unintentional. You can also define iatrogenic as a problem or complication caused by the healthcare provider with unintended consequences. There are plenty of examples of this happening within our healthcare system. It's likely that you have experienced something mild, a complication, unintended consequence by taking a medication. And of course, all medications have unintended consequences. They have side effects. And a good physician will tell you what all the different side effects can be when he prescribes a medication. In fact, the effect of medication is nothing more than a list of side effects, and he's picking out one side effect that is most important, and then you got to take all the other side effects that come with that important effect of that medication. So actually, every physician, every doctor who treats patients well and ethically has unintended consequences. And that is what we're talking about today as it applies to orthodontists can create TMD. So there are two ways that an orthodontist can actually create or facilitate, make worse, temporomandibular joint disorder. The first is when they put traction on the mandible to try to draw a occlusal problem, a dental problem that is much larger or more significant than just crooked teeth. Crooked teeth is an aesthetic problem and should be corrected if the patient wants it corrected. And that's what aligners are all about, and that's what wire and brackets are all about, and that's what orthodontists do, or general dentists who treat patients orthodontically. The problem is that it is common that when orthodontists put traction on the entire set of lower teeth and jawbone, mandible, that those teeth are embedded in, that it simultaneously pulls the lower jaw forward. And when you do that, it disoccludes or pulls the ball out of the socket. The ball is called the condyle, the socket is called the glenoid fossa, and when you do that, you can overload the joint over a period of time. When the orthodontist isn't he's paying attention to trying to get the teeth to fit together well, and in what we call in the dental dental industry, the different classifications of front teeth, you can have the normal position of lower teeth against upper teeth like this. You can have, that is called a class 1 position, where the lower teeth fit right behind the upper teeth. Now we're talking about front teeth now. And then the class 2 position is when the lower teeth sit well back behind the upper teeth. That is called a class 2. And then a class 3 is when the lower teeth fit outside the upper teeth in front, either directly against or out in front of the teeth. It's called a class 3. So this would be called, most patients know it as underbite or overbite, but doctors know it as class 1, class 2, or class 3. Again, the mandible moves, not the teeth. The teeth are not moving. The teeth are in the jawbone. But when the orthodontists try to fix a class 2 position of the jaw by tugging on the teeth, it literally pulls the entire mandible forward. And when that happens, what occurs is it pulls the ball out of the socket, and over a period of time, when the patient now is trying to chew with traction on the mandible, or even after traction is removed, and now the doctor, the orthodontist, has gotten the teeth to fit together in a somewhat normal position of a class 1 position, but the ball is now pulled out of the socket permanently and trying to function as a joint. And you can imagine whether it be a temporomandibular joint or an elbow or a shoulder joint or a hip joint that is pulled out of the socket, and you're trying to function constantly with that socket pulled apart, it is going to cause damage within the temporomandibular joint. Now, I've created, with the help of AI, I will give that credit, this little cartoon. And I hope it is significant and you can understand it. The left side basically shows the normal position of a joint inside the socket with the disc or meniscus. We call it the meniscus or disc. It's a little cushion that sits in between the ball and the socket. And that meniscus, then, when you put traction on the mandible, indicated by the arrow, will pull the ball out of the socket, can damage the meniscus, the cushion. It pushes it forward, causes it tremendous amount of loads, and then you get damage and inflammation, leading to chronic inflammation, joint compression against the temporal bone, cartilage damage, chronic inflammation, and eventually degenerative change of the bony parts of the joint itself. And that is, by definition, what TMD is all about. TMD is nothing more than inflammation, chronic inflammation within the temporomandibular joint, which creates all the symptoms. So you can see why it is essential that orthodontists or general dentists who try to do orthodontics in their office need to be aware that putting traction on the mandible, which can be done with intraoral devices, intraoral elastics, or in some cases, in extreme cases, head frames, external devices, which pull the mandible forward. And likewise, there are traction devices, either elastics or external head frame devices that literally in a class 3 position try to push or hold the mandible from growing, which is actually even worse. That will really enhance damage to the temporomandibular joint, which may not show up immediately. It may take several months or even several years for the damage to get to the point, the chronic inflammation, to damage the structures within the joint itself, to begin creating enough chronic inflammation that does not go on to healing, that will create all of the symptoms, which I will repeat again: frequent and or recurring bad headaches, earaches, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, feeling like your ear's full of water, vertigo/dizziness, upper back and shoulder pain and tightness, which is extremely common, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Once you damage the joint, then the meniscus cushion begins to get loose. It starts to click, and then it starts to pop and hold for a while, and then pop back and create pain. And after a while, then you have limited opening, all kinds of different inability to open, locking of the jaw, along with the painful symptoms and the non-painful symptoms, which are actually two separate mechanisms. The painful mechanism is totally separate and distinct from the non-painful ringing, fullness, dizziness. So that is the first way an orthodontist can unintentionally create temporomandibular joint disease. And if you have had orthodontic treatment as a young child, and it can occur anywhere between when orthodontists try to do orthodontics, and which usually as early as nowadays, age 9, 8. I've seen several patients all the way up through middle adolescence. By the way, I'm not talking about adults now. Yes, you can damage an adult joint the same way you can damage a child's joint, but it is much more easy to do in a child. Headaches is very predictable in a child, actually. Sometimes an adult can get by and accommodate the extra loads that are placed on the jaw by trying to pull the entire lower jaw forward. But on the other hand, trying to do that orthodontically does not work because the growth is complete. This issue is seen almost exclusively in growing children when growth is in play. And that's exactly when you don't want to put extra loads on the temporomandibular joint, because you can create not only temporomandibular joint, but you can enhance facial growth disharmony, facial growth problems, because the temporomandibular joint is one of the primary, if not the primary, growth center of facial growth and development. I can say that with authority because I actually had a research project for 2 years under grant from the National Institute of Health. I was a research fellow with the NIH and National Institute of Dental Craniofacial Research on the topic of facial growth and development. And the temporomandibular joint is the primary growth center of facial growth and development. And if you damage that joint as it is supposed to be growing, then you can definitely create a problem with facial growth and development as the child matures. And I have lots of experience with that in trying to fix facial growth and development problems as a maxillofacial reconstructive surgeon, in doing literally a couple thousand cases of orthognathic surgery. All that means is straight jaw surgery, making the facial structures coherent and make them so that the facial growth and development is more normal. The second way that orthodontists commonly create temporomandibular joint disorders is kind of related to the first one, but here's the problem. When they see a patient with a class 2 position of the front teeth, and they try to fix it orthodontically, they ignore or don't tell the child's parents, that the right thing to do would be to surgically correct the position of the jaw. You cannot correct a position of the jaw non-surgically. You can do it surgically, but non-surgically. But as an orthodontist, tugging on, putting traction on the mandible, all you're doing is damaging the temporomandibular joint. But the issue is, when an orthodontist is faced with a mother or father who bring a child into the office and state that, I think there's a problem. They can see that the chin is way back behind the rest of the face. More commonly than not, the orthodontist is not inclined to tell the patient that surgery is what needs to be done here, and they know and agreed upon, nobody wants to do surgery. Nobody likes to hear the word surgery. I don't like to consider having to do or having to have done on me a surgical procedure. It is something that most people do not enjoy. But it is important for an orthodontist to at least communicate with the parents that in the case of a significant jaw growth problem, whether it be class 2 or class 3, or even somewhat in the middle, that the right thing to do is do a combined treatment with the help of an orthodontist, because you can't do jaw movements without the help of an orthodontist, and a oral and maxillofacial surgeon. And that is the correct way to do it. But the problem is that most orthodontists decline to advise the parents that it is the right thing to do. And they just go and say, well, I think I can fix this by pulling on the jaw, by doing orthodontics alone. And I described where that is a problem. Now, just to let you in on our camera system, we actually have a second camera that I can again go back to this diagram and point out that when you put traction on a temporomandibular joint, it causes extra loads on the joint itself, either immediately or over time, pulling the mandible forward. And when you do that long enough, what you'll end up with is anterior displacement of the joint itself, the condyle and the glenoid fossa, which leads to joint compression, cartilage damage, and chronic inflammation. And as I said now for the third time, chronic inflammation drives all the symptoms. You're literally creating chronic inflammation within the temporomandibular joint. Not a good idea. So I want to make it clear that this is about education, educating the dentists and orthodontists, and educating the parents to understand that doing jaw surgery is surgery, but certainly not as complicated as most people think, and it's over exaggerated, certainly on the internet. Because I've done it my entire career. I don't do it anymore, but I've done it my entire career, and I can tell you that in my practice, at the end of my practice, I did most of these rather uh, complicated cases outpatient. So that is the second way that the orthodontist can contribute to temporomandibular joint disease, by not giving the patient all the information that they need, and giving them the idea that temporomandibular joint problems can be created, and that by moving a joint surgically is the right thing to do, and not trying to do it with braces, orthodontics alone. All right, I have made the point. Iatrogenic disease caused by the healthcare provider unintentionally. It's all about knowledge. It's all about understanding of the consequences, or the unintended consequences, of doing whatever that particular healthcare provider is doing. And all healthcare providers are confronted with this issue, whether you are a internist or PCP prescribing medications, or you are a surgeon doing surgical procedures, as I did for 50 years. You're always on the outlook, looking at or looking for any kind of unintended consequences to avoid them. That's the hard part of being a doctor. You can follow directions cookbook anytime you want. The hard part is knowing enough, being aware enough, being astute enough to put constant attention on not creating unintended consequences. All right. So I hope you like our new studio, which will get used to eventually. I had a lot of help in setting it up. I want to appreciate Manny's assistance in doing this. Also, one of my team members, KJ Campbell, had a big part in making this come together for me. So until next time, next Tuesday morning, which I'll pick another topic on trying to educate and define the problem and the solution for temporomandibular joint disorder. I am Tony Urbanic, and this is TMD Demystified.